Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. Today we will talk about the Prevent BCI trial that was administered in the last ECC 2024. This trial was conducted by the South Korean group of investigators under supervision of Professor Dr. John Park. Before we going to talk about this trial, I need just to demonstrate some clinical differences between us as an intervention cardiologist. As we see here in this figure, this is an angiographic image of a cranial view that demonstrating a mid-intermediate LAD lesion. And as we all see this lesion, a lot of us will considering to do PCI for that artery. If we see another LAD lesion, also an intermediate lesion, also a lot of us will do PCI and the other will not. For that reason, there is a room for the functional assessment through FFR or IFR, whatever, to assess the functionality of this lesion or this intermediate lesion. If we see the first one, if after doing FFR, that the estimated FFR is about 0.19, so at that reading we will not fix it or doing a PCI. The other lesions, the FFR assessment is about 0.75, so we will considering a PCI. So what if we take the first LAD lesion and we do a coronary imaging through IVUS, whatever the modality, the radiofrequency IVUS, the grayscale, or a virtual histology IVUS, or we doing another imaging modality like OCT. As we see here in this graph, the upper right, this is a virtual histology and the grayscale IVUS of this lesion, and if we can see it considered, especially in the virtual histology IVUS, it is a vulnerable plaque. So this intermediate lesion with a non-flow limiting through assessment by FFR, this plaque is a vulnerable plaque. Also, if we assess it through the OCT, we will see the patterns, a lot of features of vulnerability, thin fibrous cap, the plaque volume more than 70%, the minimal luminal surface area is about less than 4. A lot of these, the macrophage, the cord, the necrotic tissues, the medial plaque hemorrhage, all of these features are considered pathognomonic for the vulnerability of the plaque. So a lot of us at that time will considering doing PCI. So this debate, or this practical debate, is exactly the rationale of the Prevent PCI. So the Prevent PCI is the primary reason for, considering that the primary reason for acute coronary syndrome and sudden cardiac death is often the rupture of vulnerable plaques, which often appear mild on angiographic and are often non-flow limiting on hemodynamic assessment. Despite the evident correlation between vulnerable plaques and an increased risk of adverse cardiovascular outcomes, whether revascularizing non-flow limiting, non-ischemic, vulnerable plaques is safe and effective is uncertain. Just to remind that the difference between a stable plaque and vulnerable plaque, as we see here, is both of these lesions are an intermediate plaque, about 60% obstructing the coronary, but the stable plaque, if we study it through histology or IVUS, we will see it is characterized by a thick fibrous cap or a thick cap fibroatheroma, and the lipid core is a little bit small, and a few foam cells. On the contrary, the vulnerable plaque is characterized by a thin fibrous cap, large lipid core containing some necrotic tissues, calcification, and a lot of foam cells. Also intra-plaque hemorrhage. This is a histology cross-section of the vulnerable plaque with a thin fibrous cap, as we see. So now the aim of the study is to assess the impact of preventive PCI and measure adverse cardiovascular events among patients presenting with high-risk non-flow limiting vulnerable plaques identified through intracoronary imaging. So before I'm talking about the study design, I need just to remind you that the patient flow and the follow-up, this study was conducted in 2015 and ended in 2021. They firstly collected more than 5,627 patients with an intermediate stenosis, the human diameter stenosis more than 50%. 2,065 patients with revascularization with positive FFR was excluded. The remaining 3,562 with intermediate lesions with a negative FFR was included in the study. 1,954 not meeting imaging criteria of vulnerable plaque excluded. So the remaining 1,608 randomly assigned imaging criteria of vulnerable plaque and divided into two equally groups. The preventive PCI plus optimal medical therapy group was 803 and an optimal medical therapy alone 803. These two groups was continued follow-up for about 2 years, and a lot of them continued for the rest of 7 years follow-up. The trial design, as we all know, that if patients meet the criteria of intermediate lesions with a coronary stenosis more than 50% with a negative FFR more than 0.80, and they meet two of the following imaging defined vulnerable plaque by OCT or IVUS, minimal luminal surface area lower than 4 mm square, blood burden more than 70%, TICFA by OCT or radiofrequency IVUS less than 65 micrometer, and a lipid-rich plaque. So then we divide into two groups as we mentioned before. The primary endpoints was the target vessel failure at 2 years. It includes a composite of this from cardiac causes, target vessel MI, or ischemic-driven target vessel revascularization, or unplanned hospitalization due to unstable or progressive angina. The study design patients were randomized in a 1:1 open label fashion to either preventive PCI optimal medical therapy or optimal medical therapy alone. Total randomized participants 1,606. Median duration of the follow-up was 7 years, and the median patient age is about 64.5 years. The percentage female is about 27%, and the percentage with diabetes 31%. The inclusion criteria, including men or women at least more than 80 years, patients with angiographic significant stenosis more than 50% with negative FFR more than 0.80, and meet two of the following criteria: minimal luminal surface area lower than 4 mm square, blood burden more than 70%, TICFA detected by radiofrequency IVUS or OCT, large lipid-rich plaque by nurse. Number 4 is eligible for PCI with absorbed biovascular scaffolds or everolimus-eluting stents. Reference vessel diameter or 2.75 to 4 mm diameter, and the lesion length lower than 40 mm. Exclusion criteria: patients in whom the preferred treatment is CABG, previously stented lesions, bypass graft lesions, patients with 3 or more target lesions, patients with 2 target lesions in the same coronary artery, heavily calcified or angulated lesions, bifurcation lesions requiring 2 stent techniques, and finally contraindication to or planned discontinuation of dual antiplatelet therapy within 1 year. The principal findings: the primary endpoint of target vessel failure at 2 years, composite of this from cardiac causes, target vessel myocardial infarction, ischemic-driven target vessel revascularization, hospitalization for unstable or progressive angina for PCI plus optimal medical therapy versus optimal medical therapy alone, was highly statistically significant. P-value is about 0.0003. The target vessel failure at 7 years also showing a highly statistically significant difference in favor for PCI optimal medical therapy alone. As we see here in the curves, the primary composite outcome, target visit failure at 2 years, we see that the two lines are widely separated from the start, the first days of follow-up. As we see here in this curve, we continued follow-up of these patients after 2 years till 7 years. Also still the primary composite outcome, target visit failure at 7 years, is still continuing. The two lines are widely separated from each other till the 7-year follow-up, and also in highly statistically significant in cumulative incidence, lower cumulative incidence in favor of PCI plus optimal medical therapy. Also, if we take a patient-oriented composite outcome, this from any cause or any MI, also we will still seeing the same separation of lines in favor of preventive PCI plus optimal medical therapy. So, as regarding discussion, the rationale behind preventive PCI is to stabilize high-risk vulnerable plaques by allowing the necessary new intima to form over the stent or scaffold. This process helps to effectively thicken the fibrous cap therapy, decreasing the likelihood of plug rupture. Preventive PCI and vulnerable plaques effectively expanded the coronary artery lumen, decreasing the plaque lipid content and thickened the new intima compared to optimal medical therapy alone. In contrary to the current clinical guidelines that advocate for PCI solely for flow-limiting lesions or those causing acute coronary syndromes, the results from the PREVENT suggest potential expansion of PCI indications to include the non-flow-limiting high-risk vulnerable plaques. As in any other studies, there is the study limitations. The study limitation exactly is that it was an open label introducing the risk of placebo effects and ascertainment bias. The observed rates of the primary outcome were substantially lower than expected in both groups. The selection of imaging modality to assess plaque period vulnerability was left to operator discretion. 9% in the preventive PCI group and 1% in the optimal medical therapy alone group crossed over. The study didn't collect data to examine the cost effectiveness of preventive PCI strategy. Depth use was greater in the preventive PCI group. In conclusion, the PREVENT trial is the first large-scale randomized controlled study comparing preventive PCI plus optimal medical therapy alone versus optimal medical therapy for the treatment of non-flow limiting imaging defined vulnerable plaques. In the PREVENT trial, preventive PCI reduced the composite risk of death from cardiac causes, target visit MI, ischemic-driven target visit revascularization, or hospitalization for unstable or progressive angina at 2 years. Preventive PCI also reduced the composite patient outcome of risk of all-cause death or any MI or any repeat revascularization. And lastly, this benefit was sustained throughout the 7-year follow-up. And thank you.